So good afternoon. So welcome you all for this session on patient safety. This is probably one of the least discussed areas in our conferences. Probably, I can say this is probably the only session we have, the area of patient safety. I mean, it's all about how do we prevent adverse events, or we call them as sentinel events in ICAD. So we'll go through that. I mean, for this, I have with me Dr. Haripriya, who is the Chief of the Cataract Services at Ravindran Hospital, Chennai. Can you have the slides? Slides are not coming up. This is not, maybe not connected. Thanks. Once again, welcome you all for this session. So this is about how do we prevent adverse events in ICAD. It's all about how do we prevent the sentinel events. And for this session, I have with me Dr. Haripriya, who will talk about how do we ensure the surgery in the correct eye and also we perform the correct procedure. Okay. And we have Dr. Shivakumar, who is the Chief of Cataract Services in Aravind Tirunelveli, ensuring how do we ensure that the patient get the correct IOL power and the correct IOL design. Today we have about 25-30 different types of intraocular lenses. And we have Dr. Magesh Kumar, who was Chief of the Neuro-Ophthalmology, who will talk about how do we prevent diagnostic medical errors. So some of these presentations have got patient-related information, so maybe which may not be really good to share in the social media. So now we'll start off with one incident. This was a thing that was published in a newspaper where a doctor, it said, doctor was suspended for hernia surgery done on a young boy. So when you go through the details, there are two boys. One boy by name Danish, who had a nasal polyp, and the other person by name Dhanush, who had a hernia. So this boy, Danish, was taken to the theater, and unfortunately, he had undergone surgery for hernia. So when he came back to the ward, the parents noticed that he had a bandage in the lower abdomen, not in the nose. Then they found that there was a mix-up of the case records, and the patient had a wrong procedure. So maybe we think this is very rare, but there's a report, there's a paper called Surgical Confusions in Ophthalmology, published in Archives of Ophthalmology in year 2007. They looked at the incidents reported from the eye hospitals in New York. And these are all consecutive surgeries that were done over a period of 6 years, which is close to about 900,000 procedures. Okay? So, and of that, about 62 patients had an incident. So you have to remember, these are all hospitals. They don't do high volume. These are all low volume. The doctors may be doing 2 or 3 procedures at a point of time. But they had 62 incidents, all of that relating to wrong IOL implant, wrong eye surgery, wrong eye block, wrong procedure, wrong corneal transplant. So we have one example of that in our own presentation. So this works out to one such an incident or sentinel event happening in 15,000 procedures. So it is uncommon, but it is not rare. And they also say that if they have followed a safety protocol, whatever the process was there in their system, they could have avoided this. And again, this is another recent paper that was published in 2018. They looked at how frequent or incorrect surgical procedures within the OT and just outside the OT, where the patient is in the preparation room. And this has happened in a Veterans Health Administration hospitals. The Veterans Health Administration hospitals are the special, a chain of hospitals across whole of America that have been created just to take care of their ex-servicemen, army men, army, navy, or from Air Force. All the retired people, they go there for their treatment. And when they looked at, they have done about 32 lakh procedures, or 3.2 million procedures were done. Of that, there are about 277 safety errors, and there are about another 206 near misses, which if they have not picked it up, either outside the OT or inside the OT, this could have resulted in a safety error. So when you look at what are those safety errors, they've operated on the wrong side in 90 patients. They put a wrong implant in about 86 patients, and the wrong site, like, for example, in the vertebra, instead of operating on L3 or L4, they have operated on L1 or L2. Or they removed a wrong tooth, instead of right side, left side tooth was removed. And if you look at, this has affected not just ophthalmology, but at least almost all surgical specialties, maybe 12 or 15 specialties. But what you see on the top is the ophthalmology. Ophthalmology has got about 72 incidents. And you can say, 1/4 of the incidents happen in eye care. The next comes the dentist, and then the anesthetists and the orthopedics. These were the very common areas. So at all specialty, if you look at the error happened 1 per 20,000 procedures, but in eye care it was 1 per 10,000 procedure. And again, if you have done a comprehensive timeout, then probably you could have prevented this in at least about 30% of the patients. So these are the lessons we learned. One is eye care is important, and timeout is very important if you want to avoid those errors. Why is it so common in eye care? Because earlier we had one treatment for one disease, but today we've got several options. Even if you take cataract, there are at least 3 or 4 different ways to do it. If you take refractive surgery, we started with PRK, but now you have about 5-6 different varieties of way of doing it. And again, you got, IOLs. At least today, within our own hospital network, we use about 30 different IOLs designs. And then the power varies from anywhere between -10 to +40. So all this makes it very, very complex and makes the eye care surgery very, very error prone. But if you ask the patients, what is it they're expecting out of the services, they talk about reliability of the service, appropriate cost, transparency, they being treated with respect and dignity is what their concern. And if you ask the doctors, they talk about good outcomes, and minimizing complications by using the best of the technology. They think, if I use the best technology, I can ensure the low complication rate and good outcomes. And the safety part is not there either with the providers or with the patients. But if you look at what quality means, it has been defined by the Institute of Medicine in America. They put 6 elements. Of the bottommost of the pyramid is the patient safety. Over that only you can build on the patient-centered care, efficiency, effectiveness, which is, we are talking about complications and good outcomes. And then it's about timeliness, and in a situation there is an emergency, and equity, treating everybody equally. So these are 6 aspects of quality, and the patient safety is the most important one. And let's see how these errors happen. So, for example, this is a patient who had been advised a left eye cataract surgery. So, in our system, when a patient needs a left eye surgery, then all these details go into the inpatient admission record, to the nursing record, and into the biometry, all of that. And the patient also gets a wristband on the left hand. All this happened correctly. But when the doctor gave a block, the doctor checked everything, but when he brought the injection and gave the block, he gave it in the opposite eye. So this is what we call as an active failure or acute failure. Everything has been done well, but the person who's performing that, he got kind of confused and he gave it, and it's a very rare scenario. And why do acute failures are committed by people working at the final point of care of delivery? In the operating room, it's a doctor. The block room, it could be a doctor giving a wrong block. In the medical shop, it may be the pharmacist giving a wrong medicine, or look alike or sound alike. So all these things are called acute failures, and it is very unpredictable, and it is not carried through the care process. It's not because of policy or process or the technology. They are all correct, they are all in place, but the mistake is done by the person. So that is why, even if you have everything is fine, the person who are delivering the care should be in the present moment. If they are not there in the present moment, this can happen. But the common causes is mainly because we don't have a proper policy, we don't have a process to execute safety, to ensure that there is a safety in the process. We probably may not have a good technology to ensure that. And again, it's all about lack of protocols, poor decision making, and also lack of communication. And it's not the people who deliver the care. That person, somebody does it wrongly, but it is not because he was not present while treating the patient, but because there is a system has put him into that situation. So this is a scenario. For example, there was a patient advised right eye surgery, but when he goes to the admission counter, they enter it. The admission counter person enters it as a left eye, so everything is generated for left eye. This is a transcription error. Okay, this can happen anywhere. Even in a biometry, this can happen. And based on this, if you are going to do something, then probably you'll end up in doing something wrong. So the doctor, probably who was delivering the care, have to go through everything. Then that is where why the timeout is very important. You cannot just go on whatever the patient had been admitted for. So this is we call as a system failure. A similar incident, just to give you an example, what is acute, what is system, because you have to understand that part. So this patient again is admitted for a left eye cataract surgery. The patient had a bilateral cataract. Patient had almost the same vision you say about 636, 660 in both the eyes. But the patient really wanted to have the right eye surgery, not the left eye surgery. So when the patient went to the ward, this was a free patient, the patient saw, was talking to other patient. The other patient said, because you have that band in your left hand, they are going to operate your left eye, not your right eye. So the patient decided to remove that and put it on the right hand. Okay? But we have put the eye drops in the left eye, and we have done the biometry, everything only for the left eye. In the block room, only the wristband was verified, and the block was given, and the right eye block, and only during the timeout in the operating room by the surgeon, they found the error and they stopped it. And what actually happened is then they did the biometry for the right eye, they put the antibiotic for a day, then the right eye was operated because that is what the patient really wanted. So this is again, we can call it as a system failure. Sometimes the technology could be a problem. So here is a patient where the A scan was done using immersion method, but they selected an applanation mode. That was the time we had the transition, so they had chosen this, and thus this technical error resulted in a error in the calculation, and the patient had a post-operative refractive error. So to summarize, the safety errors in eye care is very common because it's a bilateral organ, and again, most of us, it's a high volume specialty. Many other specialties, they may do 1 or 2 surgeries, but most of us in ophthalmology do anywhere between 5 to 10 surgeries any day. There are multiple measurements involved. I don't think any other specialty has got that. And again, we also have more vulnerable patients, like people with hard of hearing, dementia, who are mentally challenged, and very old patients. So all these means that we have to really take extra care when we are treating our patients. So what we are going to discuss here in this is the wrong eyes which are operated, wrong eye injected, wrong procedures, wrong missed procedures, wrong intravitreal. These are all the things that can go wrong in ophthalmology. And some of you would have experienced this. And just to give you a context, in Aravind, when you talk about these incidents, how many of them have occurred in our organization? Last year, we had done about 7,28,000 procedures. And we had about 25 such incidents across all our hospitals. That works out to roughly about 1 incident per 30,000 procedures. And we talked about acute failure. Here everything was right, but the person who gave the care failed to be in the present. That was about 3. But you can see that the system failure, somewhere in the process, something went wrong. Not one person, but multiple people were involved. That was the majority of the cases. And again, we had about 9 near misses. That again works out to about 1 per 81,000. This, if we have not followed it up, picked it up during the timeout, we could have resulted in one of those earlier things. And here all the things were all because of acute failure, and there was only one instant there was a system failure was involved. So it's all about, majority of the medical errors do not result from individual recklessness or action of a particular group, but it is because of the faulty system, process, condition that, that lead to such mistakes or fail to prevent them. So the whole objective of the next 45 minutes is just to help you identify areas where errors can happen in your practice, understand how they can happen and how do we develop protocols, how do you reduce complexity and develop reliable process in your practice, how do you create independent checks like safety checklists for key processes, and most importantly, how do you create a culture of safety about which I will talk in the end. Thank you. So now with this, I request Dr. Haripriya to talk about how do we ensure correct site and correct procedure in our surgical practice. Thank you.
Thank you, sir, for the opportunity. Can we have these slides come up on the screen? So I have no financial disclosures, and as mentioned earlier, we'll prefer if no photographs are taken through the presentation because the content has patient-related information. In order to make it clear for the staff, we have defined 10 critical areas as areas for patient safety. And this is the list of what each of these goals are. So the goal 1 is to ensure the patient, we do the surgery on the correct patient and the correct eye and procedure. Second is the correct implant and power and the IOL design. The third is to prevent mortality and morbidity because we are also working on vulnerable patients. Goal 4 is to prevent any hospital-acquired infection. And goal 5 is to eliminate site-threatening complications like endophthalmitis, expulsive hemorrhage. Goal 6 is to eliminate medical or diagnostic errors. Goal 7, ensuring correct medication. Goal 8, ensuring correct spectacles. Goal 9 is ensuring physical safety, no falls in the premises. And the last goal, to ensure treatment and follow-up of these patients who are at high risk. Now, of these goals, we'll be covering the first 2 goals today. So I'll be focusing on goal 1, which is to ensure we have the correct patient treatment. So just to give you a scenario, there was a situation where a patient, just before surgery was started, we realized that at the timeout stage that the patient actually had the wrong case sheet. And how did this happen? So there were 2 patients, both with same names but different last names. And in the OT complex, they were there with the respective, one was a toric IOL, one patient was a monofocal IOL. Now, as the patient was called, the toric case sheet was taken, and when the patient's name was called, the wrong patient who was supposed to receive a monofocal lens was accompanied by the staff with a wrong case sheet. So at this point, this patient with the wrong case sheet, so the patient who was supposed to get a monofocal had a toric IOL case sheet, and surgery was about to start, but thankfully before timeout, this was identified. So this event was averted. So why does this happen? So as we all know, it's not uncommon to have the same name in numerous patients. So it's very important to not just rely on only the first name. So it's always important to have at least 2 identifiers. You talk about patient's name, but also include the last name and have one more identifier, like which area or care of the attender's name, etc. In our system, we use the electronic medical records. So while we are trying to, while we provide care at every station, right from the time when we check the vision to the investigations or doctor examination, we ensure that all of this, we verify the patient by taking the ID card from the patient and entering the last 3 numbers of the MR number onto the EMR. Only if these 2 would match would the EMR open. So this is how the system is set. The idea is to prevent any errors happening. And we also try to ensure the patient is always holding on and not giving the ID card to any of the staff members after the care is completed. So this is another situation when a doctor found out that the wrong eye was operated during the post-operative examination. Surgery is over. At 1 week follow-up, we realized the situation. So how did this happen? At a campsite, we had a patient who had the same vision in both eyes, and right eye was advised surgery. At the base hospital, once the patient was brought in, the same evening we had the fundus examined, a macular scar was noted, so the advice was changed to the right eye. However, the patient continued to the left eye. However, the patient continued to have the wristband in the right hand. So the advice was changed in the case sheet, but the patient's wristband was still on the wrong side. So because of that, the right eye or the wrong side was blocked, and the wrong side or the right eye was operated. So this was identified later in the follow-up period. The good news, thankfully, was that the IOL power was same in both eyes, so we went ahead at the other eye subsequently after this error happened. But this is one situation which happened. Again, very much preventable, but why does this happen and how do we prevent this in future? So after this, we realized we have to kind of modify the protocol. The doctor should document the reason in the EMR and the manual record. So one has to document clearly, why are we changing the eye from right to left? Is it really required? It has to be done so by a senior consultant, and we'll have to share this information with the entire team, because it's not just information in the EMR, but to enable the right patient flow, to have the wristband changed, counsel, so we have the A-scan, a fresh A-scan with the correct eye highlighted, inform the OT staff, the counselor also. So the whole team has to be aware of this change. And after doing this, the correct eye is marked after verifying with the wristband and the case sheet. Now, to ensure the correct eye, every step of the process is important, right from the primary examination done by the refractionist, the OP staff, the doctor, the biometric technician. Check if the correct eye is advised, if the right eye is counseled, and if the right eye is operated, and the documentation. So why each of this is saying is mentioned is because at any point during caregiving, this mistake can happen. More so if it is being handled by different staff. And typically that's the case, that's what happens. So even if you have 2 or 3 staff, one staff does not do 100% of the work. So they may be doing multiple points, touch points. So it's important at every touch point that this verification is done. So the verification, like we speak about doing a timeout before surgery, but at every point one has to do it. Even before the procedure, even before the patient enters the block room, we check to ensure that everything has been done. Is it aligned? The wristband, the eye marking, is it correct? Is the A-scan sheet attached? Do we have the IOL power, correct eye highlighted? IOL is available, the right power design, all of that. Again, while in the block room after checking for your vitals, before giving anesthesia, at the OT substore where the IOL is received to ensure it is matching, and before escorting to OT, because even at the station when the IOL is received, we realize sometimes the case sheets can switch before the procedure, before you give your block, before you drape, and the surgery, and again once more before the lens implantation, because we've also had situations where sometimes the IOL might have dropped, and while trying to pick up, you might have picked up a different lens, put it in a different box, and that could also be a mistake. And finally, once the procedure is over, the documentation also has to be correct to ensure the patient has the correct appropriate post-operative care. Now, the universal protocol is something which is very important. I think this has been said multiple times in healthcare, that this is the most important step every caregiving team member has to follow to ensure we prevent wrong eye or wrong events. One is to pre-procedure verification to confirm the correct patient, procedure, and the site. Second, again, very important is site marking, especially as sir has mentioned. Considering we have the laterality issue in ophthalmology, we'll have to take a lot of care, and a timeout is a must before starting the procedure. Eye marking is typically done as soon as you receive the patient and you're confirmed with the patient and you have the wristband and all that is done. It is done by one person in the medical team after verifying with the patient and checking with the case sheet that it is the right eye, and we also have attender before this is done, especially in children, but even adults as well. It's always good to have the attender along with them, because most of them are vulnerable patients, so it's good to do the eye marking in front of another person. The surgical safety checklist was popularized. I think we took this cue from the airlines industry, and now it's a mandate. So all of us have to have a surgical safety checklist at 3 stages. That is before anesthesia, which is the sign-in, where you verify the patient's MR number, is the correct patient, the eye to be operated, have they taken their pre-op medications, Any allergies? If so, has it been documented? Are we avoiding those medications? Do we have the wristband in the correct hand? So we have tweaked it a little bit for ophthalmology, but based on the system, you can always do a little change here and there. Check the type of surgery and IOL. Is pre-op iodine important? Because that has the highest evidence to prevent endophthalmitis. Again, time out before incision. We verify all of this with every member of the team, which is the surgeon, the assisting staff, and the circulating staff. And the sign out, so you verbally confirm the procedure has been done. Is it the right procedure? Any deviation, any post-op instructions. And each of these stages, it has to be signed, timed, and dated as well. So what is the cause of wrong-side procedure? Like I said, if most of the errors happen because the universal protocol has not been adhered to. That is, we have not checked before doing the surgery on the correct side. We also have something called as upstream errors or downstream errors. Upstream is something which happens before you've administered the universal protocol. Example, will advise itself, if the doctor has advised the wrong eye surgery, there is no way, even if you adhere to the checklist, you will be able to identify it. This is one side. The second thing is downstream errors, where you can have a problem after the universal protocol has been administered. Like in case the IOL is being changed for some reason, the patient has a rent and a new IOL is brought. At that point, you haven't rechecked. That can be a reason why you have a downstream error. But most of the time, this could be preventable if we follow the universal protocol. Now, there are situations when you have what we call as a near miss. Now, this patient had a cataract in both eyes. The patient had a mature cataract in the right eye, but the doctor end of the day, we have to realize errors will happen. We are all human, and to err is human, as we know. So, of course, we'll have to be very, very conscious. But are we also having the team vigilant enough to pick it up right when it is critical? So at this phase, the right eye was the mature cataract, but left eye was advised. But the counselor identified and brought it to the notice of the physician, which made it easy for us to change. Now, any of such events also has to be reported. So we have an internal incident reporting process. It's an online platform through the intranet where every of these incidents and these near misses are reported, not to point a finger, but just to bring in a culture of safety, to bring in a culture of responsibility. This is elevated. We also use this information in our training systems and also to influence behavior. So this is an event which Arya sir just showed where the correct process was followed until the very end. In spite of it, the other eye was blocked. And this is something which can also happen. Again, because right eye, left eye, where are we giving the block? So the doctor, you may have the marking, but the cap may be covering it, or the wristband may be in the wrong hand. But here, even if it is all right, you're able to see the mark, correct wristband. Sometimes, if you're not aware of what you're doing, we've also had instances when you can have an acute failure. So the corrective action now is that, of course, you'll have to adhere to the universal protocol and double verify. So we have one more staff also besides the doctor who's giving the blocks to ensure that we avoid this wrong eye block. So this situation is when the one patient was advised refractive surgery, transepithelial PRK, and this was most of the work in the system is done by the refraction paramedic, and this was reviewed by the doctor on a manual sheet. Now, while the procedure was being done, this was not cross-verified. So instead of the transepithelial procedure, the wavefront procedure was done. And what this happened, and this basically we had to go back and redo the right procedure a couple of weeks later. But what happened was the right method was not followed. So no verification method for the software workup entry was done. And the assisting staff also was not actually well trained or well aware of the difference in these procedures. So like I said, we went back and did the procedure. We introduced a new refractive surgery checklist after this incident, and we also ensured that our team was much better trained. So what I'm trying to say is you may need to relook, so any incident you have, any sentinel event you have, you should have an immediate you have to have a meeting, bring the stakeholders together. Again, not so much to point a finger, but see if you can make system changes, like introduce a checklist, talk to your team, and enable better training processes, to influence behavior. For all of this, you'll have to ensure you have that review meeting. This other case where this patient had chronic diabetic macular edema was advised intravitreal injection. Had come above multiple injections earlier, and this patient was advised intravitreal tricot, and patients paid for the procedure. And when the patient was about to leave, the doctor said, since the IOP is high, we'll just have a glaucoma clearance before surgery. And the glaucoma consultant deferred IVTA and said, we'll go in for anti-VEGF. However, this advice was changed in the EMR. But what happened, the counselor did not mark it clearly on the case sheet. So what happened? In spite of the clinician seeing the patient, IOP being measured, advice being changed, in spite of all this being done, all of this went for a waste. So patient again went in and received a IVTA. So I'm just saying, but these are very rare incidents, so we don't take them seriously, but all of this is situations which can help us learn for the future. So the last, towards the end, just to see an Arvind eye care system, we have had about 11 wrong procedures, wrong site. This is all inclusive, wrong injections, wrong laser, wrong site. This is out of 728,000 procedures done amongst our 14 surgical centers. And we have had 8 situations where we had a near miss, that is the wrong eye was blocked. And these are the reasons why. Of the 11 situations, 3 were acute failure, and in 8 cases, there was system failure. So which means that if you can ensure that everything happens properly, right, so the entire team has to be aware. So if the MRD staff, for example, puts the wristband in the wrong hand, there's a high chance things may go wrong. So we'll have to be vigilant, and every near miss has to be, in case you find the wristband is in the wrong hand, before surgery, that is also reported, so that that team gets a little more conscious the next time. So here the different causes were the manual documentation in the OT list was not done properly. So instead of SOR was mentioned instead of SOR with phaco. Missed A scan, so the patient could not receive an IOL on table. The wrong eye was prepared, so while the drape was put on the wrong eye, so that was one reason. The patient identification error, because the case sheet was exchanged in one patient. There was a change in advice after the other clinic opinion, because there could have been a glaucoma or retina, the eye was changed, but the follow-up was not there, so this resulted in an error as well. And a wrong eye surgery because change in advice in the base hospital for a camp patient. So when they are in the campsite and they come back to the base hospital, again, we may change the eye for different reasons as was just showed, and that could also be a reason. So what went wrong? So we just looked at the different reasons. So sentinel events, the next step, just these are the questions we'll have to answer for ourselves. How did the error occur? By whom and when was the error recognized? Who was the responsible person? Was the patient informed? That's a totally different information as to how you will handle such patients. What was done to the patients? Or what was the corrective action? There are 2 aspects. You have to do a root cause analysis and a corrective and preventive action. Corrective is that patient getting the right care, and preventive, what will you do in future to avoid such a situation? What was the outcome? Was the incident reported? Within 24 hours is mandatory. What are the policy changes? Was the patient refunded if required? And what have you made alterations in your system to prevent it? And there are barriers sometimes. Sometimes we don't want to take it that it won't happen to me. I must be, all of this can happen. So you'll have to go. It can happen to anyone in the system, including, the senior most person in the organization. And also the junior most staff should have that confidence that it's okay to speak up. If someone senior is doing something wrong eye or whatever, they should open up and say, sir, I think we'll just check the case sheet once more before you start. That's something we should also enable or empower them with. So the way to go forward is to strengthen the training, conduct regular meetings with your team, and to strengthen the incident reporting. So to conclude, the goal is to be 100% correct and not 99.9%. That is still not good enough. So you still may have an error, but you always want to be 100% correct. And for that, a comprehensive timeout and deployment of checklists by more than 1% would be critical. Thank you.
Thanks, Dr. Haripriya, for wonderfully laying out the problem and the corrective actions we need to take. I think towards the end we will have the discussion, and now we will proceed with the next presentation, which is how do we ensure correct IOL power and design, which is again very complex, and this is where we have more problems, not only in our hospital but elsewhere as well. I mean, the paper that was written in Archive of Ophthalmology 2018, almost like 2/3 of the errors were related to the IOL, and Dr. Shivakumar will talk about it.
Thank you very much, sir, for this opportunity. I'll be talking about ensuring correct IOL power and design. So it's not moving. Yeah, I have no financial interest to declare. So in 2023, across the 14 hospitals, we did about 4.5 lakh cataract procedures. And out of 25 sentinel events, 14 of them were related to the IOL, and which means that more than 50% was because of the IOL implantation. And all of them were system failures. Now, this is corroborated by published literature, and we look at two of the papers. This one was already mentioned, and there were 106 errors in the US, which were analyzed, and 63% of them happened to be because of a wrong IOL power implantation or a wrong model IOL implantation. In the NHS, in this paper from between 2003 and 2010, 164 wrong implants were reported. It was considered to become a never event in 2011. However, between 2010 and 14, in the paper, it was reported that 178 wrong IOL implants were reported during this period. So when they did the further analysis, it was noted that between 2010 and 2014, you can see that the biometry error due to technicality had reduced, but the human error had increased with more transcription errors, with the wrong patient biometry data being taken in, with wrong notes being attached, with wrong IOL being selected, and with the right and left eye being confused, and the plus and minus powers being confused. Intraoperatively, it happened because of a change in the order of the list, and also because another IOL was asked for due to a complicated surgery. Again, there were more communication errors, and wrong IOLs were brought into the theater perioperatively, that is preoperatively or in between the surgery. So how do the common errors in biometry happen, which is the main cause for wrong IOL power? So it may be the wrong patient, or for the patient, a wrong eye, and a wrong patient document attached to the case sheet. It can be a transcription error. It can be choosing a wrong mode, like Sir showed. Instead of choosing the immersion for immersion, you continue with the ablation mode. Missing the condition of the eye, like having silicon-filled eyes or eyes which have undergone laser vision correction. So let us look at some of the events and the root cause analysis. So patient X came with advanced cataract and underwent right eye IOL surgery, and he came back totally dissatisfied because he had a UCV of 660. This was improving with a -4 diopter to 6.9. So the first thing we did was to look at what was the IOL and what was implanted. We found them to be the same. On further analysis, we knew that the axial length measurement was not possible on the optical biometer, and so his eye was measured with the ultrasound biometer, and then this value was then transcribed into the optical biometer to get the IOL power calculation and to get out the IOL calculation sheet. Then we repeated the biometry and found that in the right eye, the actual power was not +17, but +12. So finding out how this happened, we found that while transcribing the data from the ultrasound biometer, the left eye's axial length value of 24 millimeter was entered in the right eye instead of the actual 27. So we got a power of +17, and this resulted in the error. So the corrective action was to exchange that IOL, and thereafter we started having the printout from the second biometer, which was used during the time of transcription for checking the transcription, and then attached to the IOL printout so that all this data could be verified. Another patient Y presented for left eye IOL surgery, and there was a post-operative refractive surprise of -2.5 diopters. Now, looking at the case sheet, again, we found that the calculated IOL power was 22.5, but the surgery record showed that 25.5 was implanted. So when we did the root cause analysis, we found that the EMR contained 2 separate A-scan records. And when we did the root cause analysis, the reason was that patient Y was measured on the optical biometer, and this data was being transferred to the patient Y's EMR. At the same time, another biometrist measured the eye of patient S and uploaded this also into the open EMR of the patient Y without checking the patient identity. So this resulted in 25.5 being implanted instead of 22.5, because by default, the latest A-scan is taken as the correct one, and the printout supplied said that it was 25.5 and not 22.5. So as a preventive action, the EMR was modified to raise an alert whenever one a scan already existed, and the alert would go to the biometrist that already one exists. Do you want to upload the second one? In another case, a patient underwent right eye SICS with acrylic IOL, and he came with a huge refractive surprise of -10. Here we found that the IOL power calculated was -6, and when we did the root cause analysis, we saw that -6 was documented in the case sheet, -6 was documented in the total case sheet which went to the operation theater. But when the circulating nurse took it to the OT store, there was a mistake where the IOL supplied was a +6. So there was a human error in reading that -6 were read as +6. The further error was that the circulating nurse did not verify this, and the operating surgeon and the assisting nurse did not verify this, and the wrong IOL was implanted. So for this, a software was introduced, used by the storekeepers, where when the MR number is fed in, it is populated by the patient details and the details of the IOL power and designed to be implanted. And when this IOL is chosen and the barcode is read, it populates the lower half, and the storekeeper can actually verify this with whatever is there in the upper field. Also, if the power varies by about 0.5, then it raises an alert saying that the IOL power is not what is actually advised. Do you want to go ahead with this? So this becomes an alert for the storekeeper to refrain from issuing this particular IOL. So when we look at what happened last year, we saw that there was a wrong manual documentation of an undercorrected power in a pediatric case. Then we had an exchange of the IOL box by the running staff collected in the OT store, just like the example that we showed. There was a patient identification due to exchange of case sheets. This became wrong in about 5 cases. After everything was checked, the unused IOL of another patient was handed over during the surgery. So again, this became a failure. Wrong lens was issued in the store, which was the wrong IOL power. And in one case, just before the implantation, the IOL had been removed out, and then it was found, before it was from the peel pack, it was found that it was of the wrong power. And luckily, at that last moment, due to the check, the implantation was stopped. And so this was one near miss which happened. In the wrong IOL design, the wrong lens was issued by the store in 5. So basically, the wrong IOL power design was not so much. But even then, the system could not change this. The software could not change this because there was nothing to check the design. It had to be manually checked by the storekeeper. So we can try to address the gap through systems and technology to minimize all these errors. However, eliminating the human component is impossible. So why do we have IOL-related errors more common among the safety incidents in ophthalmology? There are different categories of IOLs, like monofocals, EDOFs, and multifocals. And each of them, in the same category, different brands have different A constants, which may have a difference in power of up to even 1 to 1.5 diopters. Also, there are multiple brands with confusing and similar sounding names. To name a few, something like Vivid and Vivity, or within the same brand, something like Supraphobe and Superphobe. So how do we ensure a safe IOL? I don't have the mouse here, sorry. How do we ensure a safe IOL? So as said before, at every stage, we should ensure that it is the correct patient. We should confirm the name of the patient and use more than 2 identifiers to verify it: unique identification number, the age of the patient, the relative's name, or the address. And also check if the medical record into which any documentation is done is of that patient. For accurate biometry, what is important is a routine calibration at the recommended time. And generally, in the optical biometers, it is done at the start of the day when you start the machine. However, we should be careful to see that the calibration is done. It should be documented. And also that none of these steps are skipped. Again, in optical biometry, we should make sure that the correct mode is chosen, like aphakic, pseudophakic, and the status of the vitreous, like silicon oil filled or not, and whether laser vision correction is done or not. After the IOL power has been determined, the responsibility of continuing with this depends on the OT staff and the store staff. They have to check for the IOL design and power in all the documents available, that is the case sheet, A-scan record, and counseling record, and retrieve the IOL as per these records. And then this retrieved IOL should actually be checked against these case records to make sure that it is the same. And the expiry of that IOL should also be checked. After this, it is issued to the circulating MLOP and it is handed over to the assisting staff. And while receiving this lens, the assisting staff should confirm the patient identity, confirm whether the IOL issued, the design and the power matches with the patient's medical record, and also check the expiry date of the issued IOL. So to reduce wrong IOL implantation, what are the things that we can do? We should follow the best practices in capturing biometry and in IOL power calculations. So in biometry, we should follow the Holiday criteria, that wherever there is a difference between two eyes of the same patient in the keratometry reading or the axial length or the IOL power calculation, we should go ahead with measurements on 2 biometers and verification by 2 biometrists. And in IOL power calculations, we should make sure that we are using the right IOL formula and we are using the right constants. Only rely on biometry source documents, especially printouts, because we can always verify this with the data, especially if you are transcribing the data, the biometer data onto the online sheets, like for IOL power, toric power calculation, or for Barrett's formula calculation. Always have a printout attached so that you can always verify that the transcribing was right. Use the cataract safety checklist at all stages, like shown by Madam. Now the surgeon we as surgeons are the final frontier in avoiding the final error, and therefore we should religiously perform a timeout of verifying the patient, verifying the eye to be operated, verifying the procedure to be done, and the details of the IOL, the model and the implant, and not only before the start of the surgery, but the IOL verification should be done even before the implantation. We should ensure that there is an adequate stock of IOLs so that we do not end up with another model. And we should consider the use of electronic patient records as much as possible, because sometimes in manual documentation there can be problems. If we are using manual documentation, the IOL power should be written in.
Yeah. Can you just finish your talk? Can you wind it up in a minute time?
Yeah, I'll just finish the last slide. And consider highlighting which IOL has to be put up, and beware that D can be read as 0 and minus in front of 1 could read as plus. So with all these, with these we can prevent errors. Safety is everyone's responsibility, more so of ours, and if we follow these, then it is possible to reduce all the errors. Thank you.
Okay, thanks, Shivakumar. Thank you. Yeah. Maybe the next presentation will be by Dr. Magesh Kumar. How do we prevent a diagnostic medical error?
So good evening, and welcome to this instruction course. I would like to thank our chairman, Dr.R.D. sir, for having given me this opportunity to speak on preventing diagnostic medical errors with respect to patient safety. There is no financial disclosures in this presentation. So I would like to start with a case presentation. This is a patient who presented with sudden loss of vision. A young male presented with vision loss in the left eye for a period of 2 days. On examination, his right eye was 6/6 and the left eye was hand movements. We can see the anterior segment here with a hypopyon and a poor red glow. So essentially, he has had an endophthalmitis for the last 2 days. So that is the cause of his vision loss. 2 days back, what happened? He presented with a left eye injury on a Saturday evening. He had a history of workplace injury to the left eye. He was a lathe worker. and he had presented within an hour of the onset of injury. At that time, his visual acuity is normal, 6/6 both eyes. On examination, he had a small left eye, small subconjunctival hemorrhage, such as shown in this representative image. This all was documented in the case sheet, small subconjunctival hemorrhage, and he had some degree of iritis. There is no iris hole noted. He had been diagnosed with traumatic iritis with a subconjunctival hemorrhage and treated with topical steroids and home atropine and advised to review after 2 days. The next day being Sunday and advised to come on Monday morning. What exactly happened that led to the endophthalmitis? The exact nature of injury was not inquired into. He had a history of injury while working in a lathe machine, and lathe machine has got a propensity to generate high velocity objects. So as he was doing the lathe work, it was a flying foreign body, and this resulted in an intraocular foreign body, and the route of entry was situated within that subconjunctival hemorrhage in the sclera. So if the doctor had taken the proper history of what he was doing at the time of injury, he might have thought that probably it's a intraocular foreign body. It was a scleral perforations hidden within the SCH. And how do we suspect that? A proper history should have been taken, what he was doing, the nature of work, and a detailed fundus examination where there is no pain or any other antersegment findings, where there is less pain. A proper dilatation should have been performed even in the diagnosis of traumatic iritis, and a full indirect ophthalmoscopy should have been performed. And finally, with a high degree of suspicion, an X-ray orbit could have appropriately shown a small foreign object such as this one, and that could have been diagnosed instantly. So a missing clinical diagnosis such as this one can result in loss of vision, as we saw in our case. It can also result in repeated visits by the patient whenever we don't diagnose properly. It can lead to poor postoperative visual outcomes, as we will be seeing, and a wrong documentation of the diagnosis and wrong treatment can occur when all these things go wrong. So what are the other ocular conditions that will progress to total vision loss in a rapid period of time? A patient presenting with floaters and flashes, if not evaluated properly at the general ophthalmology setup, we can have a missed retinal tear or a retinal detachment, early retinal detachment, leading to total vision loss within a matter of few hours or days. An intraocular foreign body, as we saw in our case, a patient presenting having an intracranial tumor may present with headache or visual disturbance with normal vision. As ophthalmologists, we like to see the visual acuity is 6/6, your pupils are normal, your fundus is normal, everything is normal, there is nothing wrong in you. That's what we like to say. But the reality is the patient can have a visual field defect even with the presence of 6/6, and this may harbor an intracranial problem. They may have diplopia. So they will say it's normal, they'll have blurred vision. If we have 6/6 and visual fields are normal, we tend to say it's normal. But we have to ask the patient, if you close one eye, whether your vision is getting better. And if they say yes, likely it is a diplopia which is causing the blurred vision. Also, early PDR we should not miss, like early neovascularization elsewhere. A proper dilated examination should be done. Early vitritis, few vitreous cells can become a potential ominous sign. It can harbor an early endophthalmitis, not necessarily in the presence of a trauma or postoperative setting, or even in the case of endogenous endophthalmitis, this can be the first presenting feature. The patient may have had an intravenous treatment elsewhere, for example, a fever, and this could be the first earliest presenting feature. So in the case of an ocular trauma, proper documentation of all these details should be done, which will make us not miss a potential intraocular foreign body. The second situation is that when a patient presented with a post-operative vision loss. We can see with the case example, a female, 54-year-old female underwent an uneven full phacoemulsification in the left eye. We can see the quiet anterior segment and the normal IOL here, as well as the normal fundus. On post-operative day 1, she had developed a sudden vision loss. The visual acuity in the right eye was 6/36 and in the left eye was hand movements. Examination was unremarkable except a relative afferent pupillary defect. So what happened? In the presence of a RAPD, we tend to suspect a optic nerve pathology, and an immediate MRI was performed, and it showed a pituitary macroadenoma which was complicated by a pituitary apoplexy. A pituitary apoplexy can occur in a pre-existing pituitary adenoma, not necessarily the postpartum Sheehan syndrome, which we routinely read, but it can occur in any other setting also. And in this instance, a surgical stress, not only an ocular surgical stress, even a systemic surgical stress can lead to a rapidly expanding pituitary tumor and a pituitary apoplexy, and resulted in an acute, subacute optic chiasmal compression, leading to loss of vision, as in our case. So why did this happen? What happened when looking back at the history, there was a sudden defective vision over a period of 15 days. A normal cataract will not produce a rapid decrease in the vision. The visual acuity was recorded as 6/36 and the left eye was 5/60, even though the cataract was recorded as equal in both eyes. So this is the second red flag. First is the history and second is the unequal visual acuity in the presence of an equal cataract. There was, pupils were recorded as normal, but sure there should have been a trace RAPD which was missed, and fundus was recorded as normal. So we had these 2 or 3 red flags which could have been picked up, and it could have been identified even before the cataract surgery. The other conditions that can lead to poor visual outcome following a surgery could be a pre-existing amblyopia, especially anisometropic amblyopias. Always compare the IOL powers between both the eyes. A well-dilated examination is required to not to miss a subluxated cataract, as otherwise intraoperatively we might be ill-equipped to handle that. A Fuchs dystrophy, a corneal gut data has to be carefully looked for, as sometimes several months later or years later, they can have decompensation, and dilated examination to detect all these retinal pathologies like macular holes, which can lead to poor visual acuity post-op. Especially in the case of a cataract, we are likely to miss if not looked properly. High myopia, diabetic retinopathy, age-related macular degeneration, a low-grade uveitis or vitritis pre-op can aggravate. And not to say the least, all these optic nerve pathologies like optic disc edema, which can lead to acute vision loss, especially in the case of an ischemic optic neuropathy. Temporal pallor or a glaucomatous optic atrophy, if missed, can lead to a poor postoperative visual outcome. Last situation is when a patient presents with a persistent complaints of redness. Uncommonly, we see this condition. For example, this is a case presentation of a 13-year-old male patient which presented with recurrent redness and irritation in the right eye for a period of 1 month. He had been treated earlier, seen 2 or 3 times and given topical antibiotics, having diagnosed with an acute conjunctivitis. Still, he came with complaints of persistent irritation. On careful examination, we can see some pattern aberrations here. And this was the congestion, and on tarsal examination, they had minute, all these caterpillar hairs were present, minute microscopic structures. Unless looked with a high magnification in the presence of persistent irritation, we'll miss all these findings. Other examples of a red eye could be cells and flare, and if missed early can lead to a hypopia and uveitis, a foreign body caterpillar hair as we saw in our case, scleritis, episcleritis, and inflamed pterygium, and a posterior uveitis or a posterior scleritis is commonly missed, and if not looked into, it can lead to missed diagnosis. Okay. So I'll quickly sum up. So other causes could be dilated episcleral vessels, which is commonly diagnosed as conjunctivitis, which could harbor a carotid cavernous fistula or a cavernous sinus thrombosis. So in summary, we have to identify the correct patient, complete documentation of the patient history, pay attention to the special conditions, methodical examination and the necessary investigations, and correct. This has been told, double identifiers about the patient, record all the previous history, ocular and systemic, and previous surgery treatment details has to be taken note of. Of particular importance is the drug history. Anti-tuberculous treatment, ethambutol history, if missed, can lead to a poor postoperative visual outcome and lead to postoperative surprise. Other drugs like isoniazid, levofloxacin also can cause optic neuropathy used in anti-tuberculous treatment. Chloroquine can cause macular toxicity. Not to miss these histories. External findings like xanthelasma, pedal edema can be due to hypertension and renal failure and can lead to systemic problems. Stroke patients, if a patient is in a wheelchair, we need to know why the patient is in a wheelchair. It could be a stroke, and a stroke patient can have a concomitant homonymous field defect on the same side of the lesion. And operating these patients post-operatively can lead to a poor visual outcome. And pay attention to unscheduled visit and unscheduled follow-up visits, and we need to do a thorough evaluation of the same. Always avoid the lids for look out hidden foreign bodies in case of unilateral congestion. And in doubt, always do a B scan for trauma cases, a mature cataract, the presence of relative afferent pupillary defect and inaccurate projection of light in the cataracts, and OCT in suspected macular pathology. Always suspect visual field defects. In case of blurred vision with 6/6, suspect binocular visual abnormalities. In case of blurred vision, they may have a diplopia. And check if the density of the cataract doesn't match the visual acuity, do a double checking. Thank you.
Thanks, Dr. Nagesh. I mean, I'll run through the last presentation. I mean, it does not come here.
It's come here.
Yeah. So, I mean, we just heard, what all can happen. The wrong eye surgeries, wrong procedures, wrong IOL power, or you can even miss a diagnosis which can result in loss of vision or even sometimes loss of life also. So, I mean, there are two things important. One is you have to have a process. The second, you also have to have the culture of the safety. So, I mean, to err is human. I mean, that's something we have to understand. So that is where the process becomes important. But again, that alone may not be sufficient. The culture we have to bring in the team is also very, very important. I'll just run through some of the important things. The first and foremost thing, if you want to avoid such errors happening in your organization, probably you have to improve the safety. Create the awareness about the safety is very important. Bringing together everybody to understand how safe is your hospital is very important. Open sharing. And today, we are no ophthalmologist alone. Each ophthalmologist will have at least 8 to 10 people, either directly or indirectly connected to him. So, I mean, to have a clear understanding between the team is very, very important. So, that is where what goes wrong becomes important. What are the reasons for things going wrong? That's why, when you heard all these incidents, there is a lot of details. We really analyze what goes wrong and how do we make sure that doesn't happen again. And again, second is the important thing is how do you bring the culture of reporting. So we started with the paper form for people to report, but we didn't get any report almost for 4 or 5 months. But now if you can have something electronically, there are Google forms are there, WhatsApp is there. There are many things if you are able to have some way to report it so that everybody is aware. And again, not only reporting, but how there is a system for communication. Here, in our system, once it is entered, the information goes to the chief medical officer and 4 or 5 people who are in charge of the safety in the organization. And again, giving clarity to the staff, that is where, the safety goals, it becomes very important. How do you define? That's what Dr. Haripriya said, the 10 goals, and each goal you have to understand how it can be prevented in your own practice. You have to write up your own protocol for that. And again, the important thing you have to understand is all these errors are related to the work process. You have put the protocol you are following is the root cause for all the thing. In Aravind, because a lot of delegation happens, each person does one work, which means, there is a lot of handover. At least about each patient is touched by 12 to 15 people in our organization, which means, we have to make sure that identification is a fundamental thing. If you don't identify the patient, we are going to end up. I mean, you have to find out what is that important thing in your own organization. Again, the common thing is transcription error. What is the system you are going to have? You just heard from Dr. Shivakumar what we do in our organization. And Dr. Haripriya talked about in detail about timeout and OT. We do it not just in the operating table, but at 5 other different locations. And just to document that, we also have safety checklists, either paper or also on EMR. And again, what is important is the monitoring, whatever that has been reported, somebody have to look at it, and then we have to analyze it. This is a kind of a 1 year what happened in the counseling department. So these are all, these do not result in any incident, but we're making sure that even that counseling department is able to report. If you see, the counseling department reported 302 errors. These 302 errors are about the doctors, usually, or about the biometry team. And about the counseling department, the people downstream, like the medical record department or people in the ward, they report about them. And again, now when you hear all this, doesn't mean that you have done some changes, it's not going to stop. You have to constantly redesign that. So the wrong eye block is a common thing. So we went with 2 markings. It didn't help. And that is when we had a paramedical staff, and that considerably brought down the incident. Now there are 2 people who have to be there when a block is given. And again, using technology, earlier we used to have a paper record. We have to make sure that the medical record number and the EMR number, everything matches. But since we had these errors, we made sure that only if you enter that last 3 digits, that card is only with the patient, not anywhere else you cannot get this number, and only then the EMR will open. And similarly, a doctor's, like Dr. Haripriya said, a right eye mature cataract, it was wrongly advised left eye. So the EMR will also ask whether it is really a right eye. Then there is an opportunity for the doctor to re-verify. And again, Dr. Shivakumar talked about how do we check the power of the IOL in the store before it is dispensed. I mean, this is all what we do in Aravind, but you have to understand what is it you are going to do in your practice. And in a constant reinforcement is very important. It is not one person's work, it's a teamwork. I think you have to delegate and also empower the staff so that we can minimize these errors. And safety is a way of thinking and acting wherever you are, whether it is work, home, or leisure. Safety is everyone's responsibility, and we should feel comfortable to report any safety issue. That's a level of transparency, the ease of work you should bring in your organization, and this should become a part of the organizational culture. And you need to invest in the people's potential. Thank you. So if there are any questions, anything you want to ask our team, we'll be happy to answer. Maybe we have 5 minutes. Anything you want to add, Haripriya, Shivakumar, maybe another 5 minutes we have, so you can give your inputs.
I think we all have to start with something small, like starting with checklist, and then if any just monitoring with small stuff. The incident reporting we find to be very useful. So any small deviation, also the staff encourage them to report. And again, the idea is not to penalize, so that you'll have to just understand what the problem is, and that gives them a reassurance that someone is listening to them, and we're actually helping them overcome the problem. So that has also helped us in a big way.
Can I ask a question, sir?
Yeah, please. Yes,
yeah. A wonderful talk. Sir, now you have been doing so much of thousands and lakhs of surgeries. Definitely, the safety has to be the first priority, and we are already doing it, and Haripriya Madam has already published a wonderful paper. My question is, when you are doing so many eye cams, now we are tagging it with free, too many free things we are buying it. Now there are few concepts which are coming that people who wants to go in for a premium lenses or something, then you need to have the counselors at each of these camps when you are going around. So what is your take on that? Should we do that or should we not do that? Or should we remove that word free eye camps and just say that it is eye camp so that the conversion would be possible? Or how do we teach our patients how to become a better patients?
We'll ask Haripriya to answer.
So we normally in the eye camps, we only bring in, so it is along with the NPCB, so our camps are sponsored by the government. So the patients we bring in through the camps, they don't pay, so they are completely free. Those patients who are willing to have surgery with a foldable lens, which we don't do through the camps.
How do they know that there is an option called as the foldable lenses?
So I think in today's world, everyone knows, but if the patient, like example, most of them would have come and said, I want, we don't say it from the counselor's side, we don't promote it at all. Okay. But if the patient says, I want to come into I think they know that they have a better option in terms of a lens, then we'll refer them, and we have a separate count of how many we refer, and we give them a card and say you come and meet this staff at this number, and that card they bring there. So we also track how many patients have come through the camp to the base hospital, or who are referred from the paying to the free side. All of this is done. Again, in the free, when they come with a walk-in free at least, we ask every person, every patient if they have any insurance. When they say yes, then we refer them to the paying hospital. That's something which you can do. Maybe, at least in some cities, if the insurance penetration is high, at least that is one thing where you can, those patients maybe you can spend more time as a counselor, but they don't have insurance, we don't ask them, we don't give them a choice unless the patient themselves ask.
So according to your experience, because sir is telling they have time, can I ask one more?
Yeah, it's like she said, in the camp we don't promote the paying surgery or any options which we do on the paying side. But if the patient talks about it, that he wants a particular type of surgery lens, then we ask them to come to the hospital where they have to re-register and then go through the whole process.
So now the big debate is happening not to do these free eye camps and all those things. More common in the metropolitan cities now, many doctors are creating groups and awareness and all those things. How tangible it is that it will draw the paid patients? Because one of the story which I saw from Arvind is that after doing a camp in somewhere in part of Kerala, then after few years, the Malayali name board was added as Arvind Eye Care System, because patients started coming there, and that was the third name board which was added. So till today, do we have any studies how we can tangibly assess doing these free camps and how much of patients would they come for the paid section?
See, if you look at the prevalence of blindness, today it's about 0.3%. Okay, the whole 0.4% you can say in the population. But if you see in the urban area, it is 0.1% or less. If you see in the rural area, it is 0.6 or 0.7, almost like 4-5 times higher in the rural area. The second, if you take educated and uneducated, again it is like it is like 300% higher in the uneducated person compared to people who have done past their 10th standard. And again, if you see the women, it is about 40% higher than in men. Okay, I mean, these are all people, and today in Aravind, it's only 40% pay. 60% of them come through the pay, through the free, either through camp or other thing. And again, the national surveys show that only 30% or 35% are paying across the country. So unless, and even if we recently did a survey in the old Theni district, where the CSR is probably the highest, about 11,000 per million what we are doing, against a national average of about 5,000. Even there, we found that what we are doing is the incident cataracts. We are not doing the backlog, even today. About 5 times of what we do in a year is what is there as a backlog. So with all this, I don't think people cannot afford, people cannot access care.
Justified, sir. Free eye
No,
camps.
So I don't think the free surgery or eye camps may not go away. Probably it may be replaced by the vision centers or primary eye care centers in rural area, but the eye camp or the concept of free surgery will be there maybe for the next, unless you have an insurance, government covers everybody, that insurance is there, or the socio-economically country becomes much better, there is no other solution. Yeah.
Thank you, sir.
Yeah.
So this is regarding the wrong IOL power. Actually, recently we had one incident. Power on the IOL power calculated was -1, and the IOL power given to the OT was also -1. On the box also, so there was a +5.5 power IOL. Wrong packaging by the manufacturer. Unfortunately, it was not verified by the surgeon on the table, and wrong IOL was implanted. So after that, we have started verifying on the table as well. Inside the box, what is there, that also is being verified. Just an incident I wanted to...
Yeah. So I'm not sure how you can verify the power inside.
So
On
Is
the
it
lens
the
box, on the lens box.
Lens box, okay.
Inside,
Inside
not
the-
the cover, but on the lens
Okay.
box. But actually, this is can happen, but very, 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 very rare. I mean, this is probably the last common thing,
yeah, this is the
especially in
first,
today's
incident
world.
we have
Yeah, but
noticed in our hospital.
I'm sorry, it's good that you have identified this, but It's extremely rare. I think today the manufacturers, so there have been situations when we have post-op refractive surprises, it doesn't make sense, and also we go back and we look at the batch and check. But there will be something with the calculation or the way the eye behaves, but I think this should be the last cause if you don't know the cause of why this happens. But yeah, but it's good that you have this.
Yeah. But we also had instances, where we had this refractive error because we exactly implanted, because the patient needed -1 both the eyes. We implanted, one eye had almost no refractive error, other eye had a +3 error. So then we explanted the whole IOL and sent it, the power was not -1, it's something else. So that also can happen. Yeah.
Yes, sir.
Yeah, if there are no other questions, we'll close. I would like to really thank Dr. Haripriya, Dr. Shivakumar, and Dr. Magesh for their presentation. Plus, they are also quite passionate about this, and they really get involved across all our hospitals to make sure that these are all taken care. They meet with everybody once in a month across all the hospitals and go through all the way we really learn is from the near misses, not from the incidents. Incidents are very less, but the near misses where we have to learn. And once you are able to put in place a process, the whole interaction between your staff and the patients also improve. So that is where the real the benefit is there. And the way the patients develop the faith and trust in your system also will improve when you have such a process in place. So it's a win-win situation for both of us, for the doctors and also for the patient. So thank you.